Hi, everyone. Welcome to today's Present Approaches to Testing webinar on therapeutic drug monitoring for biologics and inflammatory bowel disease. I'm Dr. Matt Binnicker, the Director of Clinical Virology at Mayo Clinic, and I'm also the Chief Scientific Officer for Mayo Collaborative Services, and I'll be your moderator for today's session. Our presenters today are Dr. Michelle Becker, an Assistant Professor of Pharmacy within the Division of Gastroenterology and Hepatology, and Dr. Maria Wilrich, a Consultant and Associate Professor of Laboratory Medicine within the Department of Laboratory Medicine Pathology. Both of our speakers are at Mayo Clinic in Rochester, Minnesota. Just a few things to remind everyone of before we begin. There will be a question and answer session at the end of today's program, and you can submit any questions you have through the Q&A icon on your Zoom link. Please only use the chat function for any technical issues that you might be having. Also, today's session is being recorded, and we'll post that to our website in a few weeks. So now I want to turn things over to our presenters and thank them for their participation today.
Thank you very much, Dr. Binnicker, for that introduction. And thank you all for joining this morning to discuss the therapeutic drug monitoring for biologics and inflammatory bowel disease. As Dr. Binnicker introduced me, my name is Michelle Becker. I'm a pharmacist embedded within the Inflammatory Bowel Disease Clinic here at Mayo in Rochester. I have no financial disclosures. Off-label use of medications will be discussed. Learning objectives today include differentiating between reactive and proactive monitoring of monoclonal antibody therapies, developing a plan for therapeutic drug monitoring based considerations, interpreting therapeutic drug monitoring lab results to determine best next steps for medical treatment plan, describing the analytic methods employed for measurement of monoclonal antibody therapy concentrations and anti-drug antibodies. And I will be covering the first objectives more on the clinical side, and then we'll transition it to Dr. Wilrich to discuss laboratory considerations. First, to introduce inflammatory bowel disease, Crohn's and ulcerative colitis are chronic immune-mediated inflammatory conditions where the immune dysregulation leads to an overactive state causing inflammation. About 1 in 100 Americans are diagnosed with IBD, similarly impacting males and females. Caucasians are most commonly impacted, although there's increases in prevalence in other races as well. There's a genetic, environmental component, gut microbiome, as well as the immune dysregulation. And both ulcerative colitis and Crohn's are primarily diagnosed in individuals in their late teens to 30s, with another spike in individuals in their 50s, 60s, and 70s. Both conditions are chronic, often with overlapping medical considerations. However, surgical interventions and complications of disease can vary. Crohn's impacts anywhere from the mouth to the anus, with the ileum and colon most commonly being affected. It presents with skip lesions with normal patches of intestines in between, and can affect the entire depth of the bowel wall. Symptoms can vary depending on location, but often include abdominal pain, weight loss, diarrhea, and fatigue. Blood and stools can vary. Malnutrition is common. Ulcerative colitis presents as continuous and uniform inflammation in the rectum and colon, and ulceration is often more superficial in nature, with symptoms including urgent, frequent bowel movements, often with nighttime wakenings as well. If left untreated, inflammation for both Crohn's and ulcerative colitis can lead to permanent damage and complications, and there also can be extraintestinal or outside of the gut manifestations to consider. Pathogenesis of IBD, again, multiple considerations here with genetic susceptibility, immune dysregulation, environmental context, and microbiomes. Our medical therapies really focus on that immune dysregulation. Now, considerations for treatment, we need to keep in mind both activity as well as severity. So activity meaning the actual current level of inflammation that a patient is experiencing. Severity more looking at prognostic factors such as age of diagnosis and extent of disease. Treatment has two parts to it. The first is induction, so treating that inflammation and ideally getting healing of the gut. and then maintenance of remission, so maintaining that, and medicine is used for both aspects. If we'll look at the image on the right-hand side, we'll think about this blue box as kind of a good window of opportunity for treatment. So to orient you, on the x-axis, we see kind of a timeline of initial disease onset with preclinical disease diagnosis, and then the disease continuing on over time. The black line on the graph shows the inflammatory activity. So that's that inflammation, maybe based off of stool or blood tests, or seen with different tests. And then the red is permanent digestive disease damage. So this is more of a image depicting Crohn's, but we know that strictures or fistulas, abscesses can occur, and these are often irreversible. However, when treated well with that kind of earlier on, we can prevent a lot of complications from occurring. Advanced therapies do have response rates varying in efficacy from 30 to 60 to 70%. And we know that patients with previous tried and failed medicines or biologic experienced patients, the disease can be more tricky to treat. Now, what are our goals when we treat patients with Crohn's or ulcerative colitis? So previously there were less stringent treatment goals, and that really was more based off of symptoms, inducing more symptom control. We now know that that is not necessarily enough to reduce the risk of future complications. So we've kind of moved on the spectrum to more stringent, with really the goal to achieve mucosal healing, most often assessed through endoscopic evaluation. What medicines do we use? So first, we have conventional therapies that we will not focus on today, but they include corticosteroids such as prednisone and budesonide, which are only used for induction of remission. They should not be continued long-term. 5-aminosalicylates such as mesalamine, valsalazine, and sulfasalazine can be utilized for both induction and maintenance of remission. And immunomodulators such as thiopurines, including azathioprine and 6-MP, or methotrexate, are often utilized, generally not as monotherapy, but often in combination with another treatment option, such as our anti-TNF agents. Now we'll see over the past 25 years or so, we've had a boom in advanced therapies available for the treatment of IBD, with infliximab being our kind of first game-changing medicine in the late 1990s. And in the last 10 years alone, we've had 8 new drugs approved, as well as biosimilars and new subcutaneous versions of previously only intravenous medications. These advanced therapy classes include our biologics, anti-tumor necrosis factor alpha agents, our anti-integrins, interleukin 12 and 23 inhibitor, and then our interleukin 23 inhibitors. We also have small molecule agents, which we won't be discussing further today, our S1P receptor modulators and Janus kinase inhibitors. So you might be saying, wow, like there's been so much advancement, so many more medications available, which is excellent to be able to treat these complex chronic conditions, but there's still many limitations to our ability to treat patients. Some of those include primary non-response. So this is a situation where someone has an adequate trial of a medicine. Often that's going to be at least a minimum of 3 to 6 months, as onset of action for these medicines can be quite delayed. So we need to give appropriate time for the patient's disease to respond. But if it ultimately doesn't respond, that would be considered primary non-response. We also have concern with secondary loss of response. So this is a situation where someone may initially have good response to a medicine, but over time lose that response for a number of reasons. And then intolerance can also be a challenge of patients not being able to tolerate a medicine due to adverse reactions. So we are really working against a number of factors to try to find a good ongoing treatment approach. And one thing we can utilize to best get the best use out of any medication is therapeutic drug monitoring. Now, just to give a little bit of a sneak peek as we'll dive into this more, but with that both primary and secondary loss of response, some application of therapeutic drug monitoring with that mechanistic failure of primary non-response it's important to ensure that a patient has adequate trough concentrations before calling a failure to respond as truly primary non-response. When we think about that secondary loss of response, a couple different categories that can be at play would be a immune-mediated pharmacokinetic failure. So this would be when drug levels are low, we're just not achieving the right amount of medicine for the person, but we see antibodies are not at play, and that'll be defined further. And then immune-mediated pharmacokinetic failure can also occur where a patient's medicine levels are low and they do have high anti-drug antibodies, not allowing that medicine to work, and then we have to change medications. So I've given a little bit of a sneak peek of some of the therapeutic drug monitoring application, but let's dive into that more now. So first of all, kind of what is therapeutic drug monitoring, or TDM? It is the practice of measuring levels of drug in the body to customize dosing for an individual to achieve a goal. That might be achieving efficacy, avoiding toxicity, checking on adherence, but really there can be multiple factors at play. We'll usually see these time concentration graphs where time is on the x-axis and concentration on the y. And some common terminology with that would be the minimum effective concentration, which is a primary consideration for inflammatory bowel disease. Maximum tolerated concentration does not necessarily come into play much with our medicines, as there's a wide therapeutic range. We look at both that drug levels, that trough measurement, and keep in mind that these medicines have a long half-life, so a patient needs to be on a medicine for a while before we're going to have consistent trough measurements. And then we're also looking at antibodies with our laboratory tests, which can render a medication not effective if it is neutralizing the medicine levels. Antibodies can be considered high or low, but right now data are really lacking to understand kind of true cutoffs for clinical application in inflammatory bowel disease. All right, so that's general therapeutic drug monitoring. So of course, when we get a laboratory result, we will get a number back for that drug level. How do we figure out what trough target to select? So in clinical practice, there's numerous things that we consider to figure out that trough target. First, of course, what medication is utilized, as well as now I would add, because we have medicines that are given via multiple routes, the route of administration comes into play, such as intravenous or subcutaneous, and we'll have a visual in the next slide about that. Monitoring strategy is important to consider, proactive versus reactive. The disease phenotype. So if someone has more tricky to treat fistulizing or perineal Crohn's, we might actually be aiming for higher trough levels than simply inflammatory disease alone. The treatment phase is important to consider if someone is in those induction doses where troughs are going to still be variable versus maintenance when steady state has been achieved and concentrations are consistent. The desired response is also important, kind of thinking about those treatment goals, that less stringent, more clinical response versus more stringent, really what we're aiming for now after stride 2 of endoscopic remission and really true healing of the gut. And then the disease activity, if someone's already in remission without active inflammation versus if we're trying to induce remission, that can impact trough selection clinically. Other factors to consider on our lower left would be patient-specific factors that can increase the clearance of a medicine, such as having high systemic inflammation, low albumin, male, higher body weight, or the presence of antibodies or immunogenicity. Also, as I'm looking at a trough test, I always want to make sure that the timing is appropriate. Was it a true trough versus maybe an accidental peak, or checked mid-cycle, which we have to be cautious with given variable clearance? Medication adherence comes into play. Again, these medicines have long half-lives. So usually we're going to look back about 3 to 4 months to ensure good adherence to the medicine. Otherwise, if there's been missed doses, changes in dosing, held doses, that can impact that laboratory test today. And ensuring the patient's also using the medicine, getting the full dose with injection technique. Thinking about the route of administration, intravenous medications are depicted with infliximab on the left and adalimumab on the right. We'll see that in induction. So this infliximab is the classic week 0, 2, 6, and then every 8 weeks, although dosing is technically different than what's used in IBD. But we'll see that trough right before the week 2 dose is going to be a much higher level than right before that week 4 first maintenance dose, when we're kind of getting more close to steady state. So being thoughtful about the timing, as well as then the route. So on subcutaneous medication on the right-hand side depicted by adalimumab, We'll see a couple different dosing regimens. If a patient does not have loading doses, which we really don't do in the treatment of IBD, but it'll take a long time to get to steady state for adalimumab, probably 15 weeks or so. However, with the loading doses, we do get to steady state more quickly. I also want to point out that with infliximab, there's a two-compartment model for drug distribution, the central and peripheral compartments. So elimination is not linear, and this is why I'm always very thoughtful about making sure that timing of the trough matches up to what I believe it should be at checked right before a dose. As if it's checked mid-cycle, we really don't have any publicly available equations to extrapolate what a true trough would be. Now, in IBD, we have two approaches for therapeutic drug monitoring, proactive versus reactive. Proactive meaning whether or not the patient is doing well, I am going to be checking a trough at a specific time. And a reactive approach would be more if I have concerns that the patient maybe isn't responding well, then and only then, if there's signals for checking, then I will check a trough. Data do support proactive monitoring of anti-TNFs. Specifically after induction. So again, when we're getting to more steady concentrations during maintenance at steady state, after reactive therapeutic drug monitoring is conducted, and then before or after de-escalation, specifically noted with infliximab with this gastroenterology article from 2021. As far as our newer biologic agents, vedolizumab, ustekinumab, risankizumab, and mirikizumab, data are really not necessarily supportive of proactive therapeutic drug monitoring at this time, with more research needed. However, for reactive therapeutic drug monitoring, we see that this can be more widely utilized with anti-TNFs, with a goal of at least a 10 to 15 microgram per mil trough level prior to truly calling a primary non-response or secondary loss of response. And then vedolizumab and ustekinumab, this would be a supported approach as well, with more data needed for risankizumab and mirikizumab. When we think about that reactive therapeutic drug monitoring, so situation is usually the patient is either not responding or maybe has had some response or incomplete response. How do we interpret results from laboratory tests? So to orient you to this chart, we'll use this chart on this slide as well as the next slide as we look at proactive monitoring. But we see the drug trough on the left-hand column, antibodies, which are going to be detectable or undetectable, and then we'll look at that interpretation and preceding intervention. So for a drug trough level that is therapeutic with undetectable antibodies, if the patient is not responding, this is going to be more of a mechanistic failure where there isn't necessarily adjustments to this medicine that can be made to make it work better. And in this case, if someone just never responded, I would encourage a switch out of class. So if they were on an anti-TNF, maybe try an IL blocker if that's appropriate. If this is a situation of secondary loss of response, so let's say the patient has done really well for 5-10 years on an anti-TNF, but now we're seeing loss of response, then clinically the patient could switch in class, so to another anti-TNF or to a different class of biologic or advanced therapy. In this situation that the drug level is therapeutic and antibodies are detectable, likewise, this would still be a mechanistic failure, and those antibodies are not necessarily neutralizing of the drug, so not necessarily actually clinically significant. So I would proceed with the same intervention as therapeutic and undetectable antibodies. If a drug trough level is subtherapeutic or even undetectable, then and antibodies are undetectable, this would be considered that non-immune mediated pharmacokinetic failure. So we do have the opportunity to optimize this, and we generally go into off-label use of medication by adjusting the dose and or frequency, giving it time, again, realizing that the medicines have a long half-life. It's going to probably take 3 to 4 months to really get to new steady state concentrations and then reevaluating efficacy. If the drug level is subtherapeutic with antibodies, antibodies are likely playing a role in neutralizing the drug level. If the antibodies are at a low level, there might be potential to overcome those antibodies with escalation of the drug, so dose and or frequency. And if it's an anti-TNF, the addition of an immunomodulator if that's not already being utilized. Now, I only try to overcome antibodies if the patient is asymptomatic. Now, if they are having symptoms likely related to antibodies such as infusion reactions or joint pain, then we likely need to switch medicines. which is also the case if someone has that subtherapeutic drug level and high level of antibodies that likely cannot be overcome. As far as that definition between low and high, again, that is a very debated and not well understood cutoff clinically. For the interpretation of proactive, so this again could be a situation where a patient is doing well, but we made this plan ahead of time, so they may or may not be responding well. I'm going to look at this a little bit more through the lens that the patient is responding well to treatment. So in that case, if the patient has a therapeutic drug level, really regardless of antibodies, if that medicine level is good, they're considered at goal, and I would continue the treatment if they're responding well. If they're doing well, but they do have a subtherapeutic trough level and undetectable antibodies, I would be escalating with dose and/or frequency changes to ensure ongoing good response, as the patient would be at risk for secondary loss of response or antibody formation. If the drug level is subtherapeutic with the low level of antibodies, again, we can consider attempting to overcome them. But if they're either symptomatic from antibodies or have a high level of antibodies, then it would be important to switch drugs. To look a little bit more into the specific medications, we'll first look at infliximab. This also includes infliximab biosimilars. Our most recent 2021 gastroenterology article looks at the trough targets depending on the time of treatment. Often I'm checking this at that post-induction, so right before that week 14 or first maintenance dose, and aiming for a trough level of 10 or higher, noting that certain types of disease, such as acute severe ulcerative colitis or fistulizing or perineal Crohn's, may need higher trough levels. If someone has increased clearance factors, such as low serum albumin, high systemic inflammation, I might consider checking earlier at that week 6, right, prior to that week 6 dose. And then if found to be subtherapeutic, but without concern for high-level antibodies, optimization can occur by increasing the dose for infliximab from 5 to 10 milligrams per kilogram, and this is in line with FDA labeling. Or off-label, the frequency can be shortened, sometimes to as short as every 4 weeks, at either that 5 or 10 milligram per kilogram dosing. We do now have subcutaneous infliximab available, infliximab DYYB. And it is important to note that with the change of that route of administration, trough levels are going to be different. It does not necessarily mean that efficacy, safety-wise, it's any better or worse. We're not necessarily seeing impact there, although more data are needed. However, it's just different given that different route of administration. So Liberty trials looked at subcutaneous infliximab every 2 weeks at steady state, so at week 22. The median concentration at trough was 21.5 versus intravenous of 2.9 micrograms per mil. This is a REM switch study, and there was also a follow-up long-term study that assessed the effectiveness of patients transitioning from intravenous to subcutaneous with and without previously intensified intravenous regimens. Included patients with both Crohn's as well as ulcerative colitis, and patients were monitored at 3 different time intervals after that switch to subcutaneous. Of 133 patients switched, there was increasing relapse with patients that had more intensified previous intravenous regimens. So for example, patients who were on 10 milligrams per kilogram every 4-week infusions. Of these patients that had relapse, intensifying their subcutaneous regimen to 240 milligrams, which would be off-label per FDA labeling, every other week, so still that every 2-week interval, did usually recapture response. And this article found that that higher risk of relapse was for individuals with the more intensified intravenous of 10 milligram per kilogram every 4 weeks. The long-term study also found that 10 milligram per kilogram every 6 weeks were at higher risk. But interestingly, one other risk factor they identified was looking at infliximab serum concentration levels. So at baseline, so prior to the switch, If it then either stayed stable or decreased with the change to subcutaneous, those patients were at higher risk of relapse, which kind of makes sense if we think about that previous information from Liberty that usually subcutaneous injections are going to result in higher trough concentrations. So if it stayed stable or reduced, there was increased risk of relapse. This REM switch study does have an algorithm incorporating therapeutic drug monitoring with switching from IV to subcutaneous. I think that we still need to learn a lot more about this. And as they checked at that week, that first visit between 4 and 8 weeks post-switch, medications concentrations are still quite variable. I'm not sure if that's the best time clinically to check. However, I think therapeutic drug monitoring will definitely come into play as we think about these medicines that are now offered via intravenous and subcutaneous routes. Adalimumab and biosimilars, trough level goal during maintenance, which is usually when I check, usually about 4 to 5 doses or 8 to 10 weeks in, aiming for usually a trough of about 12 or higher, with the potential to off-label increase to weekly dosing. This is the Poetic study, which is a prospective observational multi-center cohort study, including 98 patients with Crohn's. And this looked at the development of anti-adalimumab antibodies over time in correlation with clinical and inflammatory outcomes. So patients had home visits and lab draws multiple times during induction, as well as every 3 months thereafter. And interestingly, it found that 1 in 3 patients did develop antibodies. Of those patients, about a half occurred as early as week 2, with 80% or so occurring by week 14, suggesting earlier development of anti-adalimumab antibodies, perhaps playing a greater role in primary non-response compared to secondary loss of response. And antibody development was associated with primary non-response, while an adalimumab drug level at week 2 of greater than 6.7 micrograms per milliliter was associated with clinical remission at week 14. So I think this is just important. I think it reinforces the consideration for proactive therapeutic drug monitoring with adalimumab to identify earlier on if there's concerns with drug levels or antibodies. I'm not necessarily convinced, looking at kind of the larger body of literature, that a week 2 trough is necessarily indicated. However, I do agree with a proactive approach. For vedolizumab, where reactive therapeutic drug monitoring is supported, generally aim for a maintenance trough of about 10 to 15 or higher, with the ability to shorten the interval. And we'll see, similar to infliximab, there is now the subcutaneous form of vedolizumab available. Previously, vedolizumab has only been intravenous. And we'll see that the trough concentrations overall are higher numbers with the subcutaneous administration. The visible 1 and 2 trough concentrations of 34.6 and 30.2 were comparative at the same time as intravenous of 11.1 micrograms per milliliter. Likewise, patients on vedolizumab, sometimes before transitioning to subcutaneous, might be on a more escalated intravenous dosing. So the study out of Norway looked at this population and the maintaining on subcutaneous vedolizumab after switching from intravenous. Ultimately, most patients were able to continue, and I think from this study, it just is interesting to note that those vedolizumab median serum concentrations at trough at 26 weeks, so like that steady state, was 47.9, which this would be much higher than what we've seen with intravenous vedolizumab. And this isn't necessarily relating to clinical outcomes, but rather an interesting observation of the difference in the subcutaneous route. Ustekinumab trough levels, I often look reactively during maintenance with a goal of at least 3. However, some studies do even identify a trough of up to 4.5 or higher might yield a better endoscopic and biochemical response for reduced inflammation, with potential optimization strategies of a reinduction infusion. This medicine starts with a single infusion dose and then at-home injections, so an extra infusion or shortened interval off-label. Now, finally, we'll discuss risankizumab, which is one of our newer agents available. You'll see that I have trough medians listed here, not necessarily goals, as we do still need more research on outcomes related to troughs. But at steady state, which is going to be defined as about 28 weeks after the start of treatment, with the lower dose maintenance dosing of 180 milligrams. A median trough of 4.1 was identified compared to the 360 milligram maintenance dose, a median trough of 8.1. As far as adjustments go, I think we again have a lot to learn. If someone is on a maintenance low dose of the 180, perhaps they can be adjusted to the high dose, which is FDA approved of the 360 every 8 weeks, or a shortened interval. Just have a visual on this one. I'm going to orient you to this population PK model. Predicted risankizumab serum concentration versus time profile, which is from the 4 to 5 clinical trials. And to orient you, the x-axis is time here, with week 0 being actually the start of the maintenance phase. So these individuals would have already received 3 IV infusions at weeks 0, 4, and 8. And then this week 0 is really truly the 12 weeks into the treatment. So that's why we see that drug levels are already quite high here. And then the at-home injections are continued every 8 weeks, and they're subcutaneous, which again makes sense with the curve that we're seeing. And per the package insert, the C trough at steady state, again, as I mentioned, with 180 milligrams, or the light orange line, is 4.1, while the dark orange line, or the 360 milligram dose, was 8.1. Steady state for this medicine is probably achieved prior to that week 28 dose, or prior to the 3rd at-home injection, with the median troughs pointed out here. So in inflammatory bowel disease, it is exciting that we have more treatment options for our patients with these complex chronic conditions. And it is very useful to have tools to better monitor our medicines to ensure efficacy, and then make appropriate treatment changes when indicated, looking really at that big picture, thinking about laboratory, clinical factors, as well as patient-specific factors. Thank you for your time this morning, and I have the pleasure to transition over to Dr. Wilrich.
So thank you, Dr. Becker, for this informative presentation on how the test's results are used for patient management. So I am Maria Wilrich, and I will talk now about the laboratory tools that we offer to monitor biologics. My only relevant financial information is due to a patent related to liquid chromatography mass spectrometry quantitation of monoclonal antibody therapeutics. This is the timeline of test development at Mayo Clinic. The first biologic test we brought live was in 2015, was for infliximab, followed by adalimumab, vedolizumab, ustekinumab, and risankizumab. So they follow the timeline when the drugs were brought to the market. I want to start by showing you the immunoglobulin structure, because our testing starts with the premise of the immunoglobulin structure. The monoclonal antibody therapies that we are going to discuss, they are all IgGs, and an intact IgG has about 150 kilodaltons, and it's composed by 2 heavy chains and 2 identical light chains. Can you see the mouse when I point? I'm not sure. So I will speak without trying to move the mouse too much. But briefly, the light chains and the heavy chains are held together by disulfide bonds. Here you can see in gray a couple of disulfide bonds putting together the light chain and the heavy chain. And that's important for our analytical methods employed for immunoglobulins. So let's first start with infliximab. The first method we brought live, we started development around 2012, and it was challenging. At that point, no one had done this for a clinical laboratory, but this method had been employed by pharmaceutical companies before, the ones trying to develop infliximab and other monoclonal antibody therapies. So briefly, what we do here is we add trypsin. Trypsin is an enzyme that cleaves certain amino acids, lysine and arginine, and it creates smaller peptides of infliximab and of everything else. Since infliximab is chimeric, means it has a 30% sequence that's murine, that comes from from animals, we don't find that sequence in human normal immunoglobulin repertoire. So we were able to identify that peptide as a signature peptide for infliximab, and then we measure that using mass spectrometry and using a standard curve that can quantitate that amount of peptide and correlate that to the amount of drug. There's been numerous process improvements over the years. This used to be a 2-day test in the lab, and currently it's only 4 hours. The test is very robust, precise, and we perform thousands of specimens every month. The drug concentration for infliximab matches well across various methods. So we have participated in numerous method comparisons with other institutions over the years. And what we see is generally the drug concentration matches very well. So you can see here in these linear regressions, the slope is generally around 1 or very close to 1, except when an analysis with a point of care instrument was performed. The last one here, the human POC, that we found a slightly higher difference, with a 25% bias, more or less. But generally, for the central clinical lab assays, the drug concentrations match very well. There's a second component to the test, as Dr. Becker already explained. These drugs are very large, they're antibodies, and they may elicit an immune response in the individuals. And that's what we call anti-drug antibodies, or ADAs. I'll probably talk about ADAs for the rest of the talk. And there are different types of ADAs. The most clinically significant ones are the neutralizing antibodies that will prevent the drug from binding to its target. So it blocks the FAB sites. And then the epitopes are no longer free to bind to the drug target. So they impact drug clearance, because when we form immune complexes, generally our immune system is targeted to destroy the immune complexes. Some antibodies may be transient and may be overcome. And the most clinically significant ones are the ones that affect that drug clearance. There are several methods available to measure the formation of anti-drug antibodies. The first one that came to the market was this mobility shift high-performance liquid chromatography. And all we know about these anti-drug antibodies is that they target the drug, right? So the drug is generally used as a reagent in the test, and then we need to identify it to differentiate it and to detect it in the analytical assays. So here you can see infliximab is labeled with this 488 fluorophore, and then when bound to any anti-drug antibody, it will form complexes of different sizes. And you can see on the bottom image here, the immune complexes have different size, and if you have a standard curve, you can quantify the amount of anti-drug antibodies present. Several other platforms are available to measure anti-drug antibodies, and they all generally rely on forms of labeled forms of the drug, biotinylated, or different labels here, and they will form a bridge. So this is what we call the bridging immunoassay. So there is a bridge formed between the anti-drug antibody and different forms of labeled drug. And you can have different things on the plate to make this detection. What are our assays like, Mayo Clinic? So before we go into that, I wanted to state a definition that's usually talked about for immunogenicity assays, and it's drug tolerance versus drug sensitivity. So a drug tolerant assay means the assay can detect anti-drug antibodies even in the presence of drug. And a drug sensitive assay cannot, means the assay cannot detect anti-drug antibodies in the presence of any drug. Majority of the assays available for anti-drug antibodies are drug tolerant, and you've seen from Dr. Becker's presentation that the troughs expected to be therapeutic generally are 10s or 5s or 8s. So there is drug in circulation if the patient has therapeutic concentrations of the drug, if they are at target. If there are antibodies to the drug present in serum, so start with that serum tube there on the left, they generally will be complexed to the drug. And a way to mitigate and to disrupt this immune complex is to add an acid dissociation step where we free the anti-drug antibody and the drug, and at the same time we add the reagent forms of the drug that are labeled with different detection agents here. And then we hope that there will be a competition. We add those labeled forms of the drug in excess, and that labeled form of the drug will form a bridge, and if present, will have a signal. So several of our assays employ this format. So we call them electrochemiluminescent assays, so ECLIA. And they all employ this acid dissociation pre-analytical step before the testing is actually conducted. This concept of drug tolerance is easier to explain when you have some data in front of you. So thinking about the infliximab anti-drug antibodies, for example, we have an analytical measuring range from 20 to 1,250 in the lab. And we had 5 samples, so looking at the rows there, and they had no drug detected in all of them, but they had different varying concentrations that span that measuring range for the anti-drug antibody detected. And we did this experiment to try to see what would be the effect of adding drug, how drug tolerant was our test. And you can see that when you add 5, 10, 20, 60 micrograms per mil of infliximab, you can still see a positive result for that first sample that had a very high anti-drug antibody to start with. But as the initial concentrations are lower, there is a different degree of drug tolerance, right? So if you have a low anti-drug antibody titer to start with, if the patient has a lot of drug in circulation, eventually that will be negative. The red information here is negative. So we always say it's a balance between how much anti-drug antibody is present and how much drug is present in circulation to determine that drug tolerance of the assays. And in our tests, we generally comment on that. In the panels that we have live, we generally comment on that. Challenges for method comparisons for anti-drug antibodies are numerous. And I think the main one is that there's no reference material. NIBST actually, they created a standard available for infliximab using a neutralizing antibody as a standard. And the assays across the different labs, they will employ different calibrators, different units for test results. So it's hard to compare, especially quantitatively, lab test results from our lab with other labs. So you can do that qualitatively, we're looking at agreement, negative, positive, or semi-quantitatively. If you have a good establishment of what's a low titer, what's a high titer. But we also know that that's a bit challenging yet with all the assays out there. I have a few method comparisons here along the years for the anti-drug antibody for infliximab. And because of those challenges that I highlighted, you can see that the agreement is generally in the 85% range or 92% range. This was a reporter gene assay, and these were 2 ECLIA assays, so 2 electrochemiluminescent immunoassays comparison. And we found about 84% agreement with this other vendor. And it has a lot to do with how we determine what is a positive, right? How does the lab define that cutoff for a positive anti-drug antibody as well? And we have done further studies where our cut points seem to be clinically significant, and the positive test results from our assay seem to correlate with worse outcomes for patients. I don't have that data shown here, but we consider the detection rate of our anti-drug antibody test to be very well correlated with clinical management for patients. When we went live with infliximab in 2015, we went with this reflex strategy, and we decided that we would only perform the anti-drug antibody when the drug level was below 5 micrograms per ml. At the time, the main indication for testing for infliximab was the reactive therapeutic drug monitoring. So we saw a lot of that. And you can see that the positivity rate for the anti-drug antibody for infliximab is about 14%. Then last year, when we decided to go live with the panel, because we acknowledge the practice has changed and there is indication for proactive monitoring today, and there are certain cases that maybe don't fit the specific guidelines. When you have pediatric patients, for example, you may want to keep them on the drug for as long as possible. So here, when we did this, we reassessed the drug tolerance of the assay, and we came up with what we are calling high titer anti-drug antibodies when they are greater than 500, and low titer anti-drug antibodies when they're less than 500 by our assay. And in the comments that go out with the test, we are helping the provider interpret the test by telling them, hey, we found a drug tolerance of up to 10 micrograms per ml of infliximab when the anti-drug antibody titer is low to start with. So we have that commentary information. But how often do we see that? How often do we see positive anti-drug antibodies when the drug concentration is greater than 5? Since the panel went live last year, we haven't seen a single case yet that has been positive for infliximab ADAs and had therapeutic drug concentration. So supporting that idea that those antibodies are generally not that clinically significant, and we don't see them very much in practice, at least for infliximab. I wanted to point out that we have validated most of our tests for the biosimilars that are available on the market for infliximab and adalimumab. We haven't found any differences on the measurement considering the reference product or the biosimilars. And we are not considering the validation efforts mandatory for every new biosimilar that comes to the market. And we don't do that for the small drugs as either, right? We don't validate every new acetaminophen that goes on the market, for example. So that makes sense in that regard. Adalimumab, that's next. That was the second assay we brought live. Because adalimumab is fully human, we could not make that mass spectrometry tryptic peptide approach work, and we ended up going with an ELISA. And the ELISA uses two anti-adalimumab antibodies that are different. They're not the same. They have different labels, and they form this bridging to detect the drug. The anti-drug antibody for adalimumab is also a bridging immunoassay, and similarly to the infliximab assay, it has that acid association component to it, and then the labeled forms of the drug compete for any drug that's present, and we hope to form that bridging bridge at the end with signal detection if there is anti-drug antibodies. A method comparison for adalimumab, sorry, I went too fast, shows 92% agreement with the reporter gene assay for the drug concentration, and the linear regression here is also with a slope around 1. And we have about 79% agreement for the anti-drug antibodies for adalimumab as well. Similarly to infliximab, when we went live in 2017, we went live with a reflex strategy only, and we had that cut point of 8 to reflex to the anti-drug antibody test. We have about 40% of our tests reflex, and the positivity rate in that cohort is still 40% of all the samples we receive for testing. So quite high immunogenicity observed for infliximab when the drug concentrations are subtherapeutic. Then when we went live last year with the panel for adalimumab plus the anti-drug antibody, we did that same exercise that, when we have high concentrations of drug or above 8 micrograms per ml of adalimumab, we saw a 2% positivity rate now with anti-drug antibodies in that cohort. They're considered low titer though, so we have seen them present with about 25 micrograms per ml of drug, and a result of 24 when a positive is greater than 14 for this test. And here we have determined 3 ranges to categorize the anti-drug antibodies. So we have a low titer range when the antibodies are between 50 and 150, and then an intermediate range between 150 and 500, and a high titer range when the antibodies are greater than 500, and they have a different degree of drug tolerance. And this is also stated in the lab test catalog and in the comments that go out with the panel for the assay to help providers interpret confidently the test results that they have in front of them. Vedolizumab. Vedolizumab was the first biologic or the first TMAB that we employed this concept or this method that we call MIRAM. MIRAM stands for monoclonal immunoglobulin rapid accurate mass measurement. And we start with a purification step, enriching for immunoglobulins and removing other proteins from the serum. And there's a second step where we break that immunoglobulin apart. So we break it into heavy chains and light chains. And at some point, after it goes through chromatography and it's subjected to a time-of-flight mass spectrometer. And in a normal patient, you would see a normal repertoire of lambda immunoglobulins and kappa immunoglobulin light chains. And if you have a monoclonal antibody, you would see that stand out of the polyclonal background, like represented here. In this case, this is a lambda monoclonal antibody that's shown here. And you get the message by looking at this screen again with different examples. So in a normal patient with normal immunoglobulin repertoire, you see a Gaussian type of distribution between the lambda and kappa light chains that the patients have. And when you have high concentrations of a monoclonal antibody therapy, you see that as a spike above the polyclonal background, and we are able to measure that signature light chain mass. Shown here is when the light chains have acquired 11 charges on the mass spectrometer. So vedolizumab employs this method, this MIRAM principle, and we add an internal standard to the specimen, do that immunopurification to enrich for immunoglobulins, use a reduction step to break the immunoglobulin into light chains and heavy chains, and then go through chromatography and use a Q-exactive platform for the mass, accurate mass of the light chain. And the anti-vedo antibodies is the same method as used for infliximab. It applies that acid dissociation and it has the same measuring range, basically. And here I'm showing a couple method comparisons to support accuracy of the test. So you can see different mass spec methods tend to correlate well, and a few different ELISA evaluations have a slight bias, but still within 20%, 25% difference for vedolizumab. And the anti-drug antibody had a 94% agreement when compared with another ELISA available on the market as well. For vedo, when we went live in 2019, the therapeutic concentrations were not well determined yet what was a good trough for patients. So for this go live, we decided to offer a reflex approach, and we also decided to offer the panel at the same time. So there is this reflex approach that will only perform the anti-vedolizumab antibody when the drug level is low. And there is the panel available as well. About 80% of our orders are for the panel, and they have similar positivity rate for for vedolizumab antibodies, regardless of the drug level. So here, for example, I'm showing the highest concentration of vedolizumab we've seen was about 44 with a greater than anti-drug antibody. Ustekinumab is an ELISA, and the tests are identical. They are both bridging assays, and they only have, a difference in what's coded on the plate. Either you use ustekinumab labeled forms or you use forms of an anti-ustekinumab to detect the drug. Ustekinumab is only available as a panel, and like vedolizumab, it has a very low immunogenicity rate of about 0.2% of positives only when you have very low drug, and 0.8% when you have a high concentration of drug. And I wanted to show this image here that we see the very high titer anti-ustekinumab antibodies are present only when there is very low drug concentration present. When you have therapeutic concentrations of the drug, you start seeing several of the low titer anti-drug antibodies. And I have a question for Dr. Becker later. How can you overcome this? What are some of the decisions made when you find that low titer anti-drug antibodies? And last but not least, risankizumab was the last test we brought live now at the end of March. Also uses this mass spectrometry approach, and now we are coding. We have an enrichment step using interleukin 23. And that provides us a very wide measuring range from 1 to 100. And we can measure that signature light chain mass of risankizumab using a time of flight instrument, very similar to what we've done for vedolizumab. The anti-risankizumab antibodies go live is planned for the fall. And we also expect very low immunogenicity for risankizumab, like vedo and ustekinumab. When we validated the test, given those dosing differences between the different conditions, for Crohn's, for example, you have the 3 IVs, and then you can have subcutaneous dosing of 180 or 360. And you saw from Dr. Becker's slides a trough of between 4 and 8 for that cohort. And you can see that Crohn's patients, they present with higher circulating concentrations of risankizumab compared to the psoriasis patients, supporting the data we've seen in the clinical trials. Here is a summary of all the tests we offer, their measuring range, the method we use for the anti-drug antibodies, what's a cutoff for positive, and the offers we have for the test. And I expect our test menu to keep expanding over the years. In summary, reactive monitoring is indicated for infliximab, adalimumab, vedo, and ustekinumab. No data available yet for risankizumab. Proactive monitoring is recommended for TNF inhibitors. Keep in mind the numerous patient and drug-specific considerations when developing a plan for therapeutic drug monitoring. And it is essential to look at the full clinical picture to best interpret TDM lab results and determine the ongoing medication plans. Several lab analytical methods are employed for measurement of monoclonal antibody therapies, the drug concentration, and anti-drug antibodies. And you can see some of my observations there with the tryptic peptide, intact light chain methods, ELISAs, ECLIAs. And my final comment is that the drug quants generally compare well across methods, and the ADAs, the anti-drug antibodies, are more difficult to compare. That's the end of our presentation. We are open for questions and answers. Thank you so much.
Great. Thanks, Dr. Wilrich, and thanks to both of our speakers, Dr. Wilrich and Dr. Becker, for a really informative presentation. We're going to open it up for a few minutes of Q&A. So there's a Q&A link at the bottom of your Zoom page. If you have a question, please feel free to submit it. We've got a few minutes for our speakers to handle those questions. I think we should kick it off, though, with the question that Dr. Wilrich posed, which is related to the topic that was brought up a few times throughout both presentations related to anti-drug antibodies. And are there strategies, Dr. Becker, to overcome when that situation arises?
Thank you for this question. So overall, literature is somewhat sparse on this, with the most support with infliximab or adalimumab making sense, as that's where we most often would see antibodies. There was a study looking at about 20 patients or so. That's our most robust study with patients with infliximab antibodies, and different tools utilized was either increasing the dose of infliximab from 5 to 10 milligrams per kilogram, shortening the interval between infusions, so perhaps from every 8 to every 6 or 4 weeks, both, so increasing dose and shortening interval, and or adding an immunomodulator, which we know with anti-TNFs can prevent immunogenicity, but also considered to overcome those antibodies already formed. So between those different strategies, again, so it could be kind of any of those individuals or together, there was not one strategy to be shown more effective, but things that were important were a lower level of antibodies when they were detected, as well as earlier time to identifying antibodies in treatment. And then between those different strategies, there was success in often overcoming them.
Thank you.
Great. Just looking at the Q&A, I don't see any questions that have been posed by any of the participants. I guess one final question I would ask of both speakers is, precision medicine, personalized medicine is all the focus in healthcare. And are there any emerging trends or technologies that you see coming down the pipeline that will allow for more of a personalized treatment or diagnostic approach in patients with IBD?
Yeah, so I can try to go first. I see a lot of models, complex models being created to customize and personalize treatment. And I see therapeutic drug monitoring as being one piece in that block of, different pieces of information that are added there to help personalize treatment along with, the intensity of disease, failed treatments in the past. And, I think that Dr. Becker had a very nice slide where she showed all the differences between patients when you are suggesting that trough target. So I do see a few computerized or artificial intelligence models in the pipeline to help us further manage these patients. Yes.
Great. Yeah, thanks for that response. Definitely artificial intelligence and algorithms should transform the way we care for a lot of diseases. All right, it's the top of the hour, so I think we'll wrap up. I want to thank everybody for participating in today's Present Approaches to Testing webinar on therapeutic drug monitoring for biologics and inflammatory bowel disease. If you have questions that do come up, please include them in the evaluation. There was a link posted in the chat that will be able to take you to the evaluation form. Laboratory credit is extended for this program, and upon finalizing your evaluation, you'll have the option to claim credit and print out your certificate. If you'd registered for this webinar and joined by phone only, you can email at mcleducation@mayo.edu if you don't receive that evaluation. And just as a final reminder, we did record this presentation. It'll be archived on our website in a few weeks. So thanks again to both of our speakers. Excellent presentation. Thanks to all of you for joining us, and have a great day.
Thank you.